there is a strong unmet need for novel biomarkers in GCA. Indeed, CRP may be unreliable in case of patients treated with tocilizumab, as may display normal values also in case of relapsing disease. In this regard, we aim to assess whether serum complement factors C3 and C4, whose activation has a paramount role in several autoimmune diseases, may also be considered reliable biomarkers in GCA. Thus, we retrospectively enrolled all GCA patients from our vasculitis center who underwent C3 and C4 measurement at baseline. 139 consecutive patients were enrolled, and all of them displayed normal C3 and C4 serum levels at baseline. Both C3 and C4 values, on the other hand, decreased significantly between baseline and the first follow-up evaluation at remission. When patients were stratified according to disease activity, C3 and C4 appeared significantly reduced in patients in remission and in full remission. In patients in remission, CRP levels correlated strongly with C3 and C4. A correlation of CRP with C3 was also found in active patients at baseline, while on the other hand, C4 levels were not associated with CRP at baseline and at relapse. In patients treated with tocilizumab, serum levels of C3 and C4 appear even lower than the patients attaining remissions with conventional immunosuppressants. In this cohort, no significant correlation was found between C3 and CRP and C4 and CRP. Finally, no statistically significant correlation was found between complement factors and imaging, ultrasonography, and PET findings. In conclusion, serum C3 and C4 do not seem to provide any added value in the diagnosis of GCA, as normal values do not rule out active vasculitis. However, serum levels of C3 and C4 do correlate with disease activity. In particular, in patients treated with tocilizumab, C3 and even more the C4 levels are even lower than the ones on treatment with conventional immunosuppressants. As the low C4 complement levels found in tocilizumab-treated patients are not correlated with CRP levels, CRP should be therefore further evaluated as a potential biomarker in tocilizumab-treated patients, in whom, as we know, CRP may be unreliable. Preliminary data coming from another cohort have indeed displayed that C4 may increase in case of refractory or relapsing patients treated with tocilizumab. This may suggest that the reduction of C4 assessed in our study is related to disease activity and not only to the pharmacological inhibition of interleukin-6. In conclusion, this confirms that C4 can be considered a potential reliable biomarker in GCA patients treated with tocilizumab.